I'm Tyler Stewart. I'm one of the medical oncologists at UC San Diego. So I just want to be crystal clear about this. I'm asked to give a conversation about a highly specific and sensitive test and talk about how the other tests still have a really good role. Against, I'm just going to go ahead and say it, I'm just meeting Philip Koo here for the first time, but on the Radar 6, there was a senior author to that, and want to guess who that was? So it's a big role. I'm going to do my best. So here we go. Here's some disclosures. The task. So is there a role for conventional imaging now? So this is what I'm tasked to do, is talk about whether or not there's a role for conventional imaging now, and what about 5-10 years from now? And here are some arguments that I just do not think make any sense. It's the learning curve. So some people might argue with PSMA scans that, we still don't know how to use them. There are lots of single bone rib lesion. What do we do with that? No. These tests are fantastic. We are going to learn. There are going to be some bumps in the road. The other thing that I'm not going to talk about today, but I should, is the cost of these, because the cost is going to change over time, and the cost from one country to another country is totally different, which is what Dr. Koo was saying earlier. What I will talk about, though, is has it been shown to benefit patients? I think that this is a really important conversation. So let's look at the data. So here is where PSMA scans really have proven their worth. Here's the ProPSA study. A lot of these studies you'll have heard about earlier today. This is a randomized study using gallium PSMA scan versus conventional imaging with a new diagnosis of high-risk prostate cancer. And here, PSMA accuracy significantly walloped conventional imaging accuracy, 92 versus 65%. Clearly showed that in the localized setting, this plays a major role. Sensitivity and specificity all looked outstanding. Here is another study. This is done by Tom Hope, looking at the utility of PSMA scans to identify patients with at least lymph node positive disease in patients who are undergoing a radical prostatectomy. And what you found here was that PSMA scans were about 40% sensitive, 95% specific, with a positive predictive value of 75 and negative predictive value of 81%. It is important to know that in this, 5 of these patients who had no nodal positivity based on their pathology actually ended up having recurrent disease or persistent disease, and actually PSMA scans further actually identified patients who probably still had those lymph nodes that were positive and just weren't taken out at the time of surgery. So it probably undervalues the sensitivity and specificity there. So here is another study. This is the Osprey study. Again, looking at disease in the localized. There were a couple of groups in this. High-risk prostate cancer, planning to have a radical prostatectomy. Primary endpoint here was sensitivity and specificity. The results here showed that sensitivity was, again, around 40% to identify patients with lymph node positive disease or extrapelvic lymph node or extrapelvic Mets, and specificity up to 97%. It actually didn't meet its primary endpoint, or at least one of the co-primary endpoints, which was the sensitivity, which was the aim was to get it about 60%. Still here, showing significant ability to identify lymph node positive disease and metastatic disease. So that's in the localized untreated setting. What about the biochemical recurrence setting? This is the Condor study. This is a study that looked at biochemical recurrent disease and had standard of care, negative standard of care imaging. They got a PYLARIFY scan. Primary endpoint here was correct localization rate, essentially a way to measure a positive predictive value in around 208. And in this, that CLR was 84 to 87% based on the 3 independent readers. Some of these patients even had fluciclovine scans, negative fluciclovine scans, and this still picked up disease in around 90% of patients. Much better for PSA greater than 0.5, but even PSA less than 0.5, 73%. So really, I think that the door is closed on conventional imaging in this setting, which I think is what Dr. Koo was saying. So new diagnosis, unfavorable, intermediate risk, high risk disease, very high risk disease. This is your, this is your puppy. Biochemical recurrent disease, also here. But where may conventional imaging actually play a role still? Well, here are a couple of different settings that the data is not totally clear. Active surveillance, non-metastatic castrate-resistant prostate cancer, and we'll talk about that. And then, most importantly, metastatic disease in the hormone-sensitive and metastatic CRPC. So active surveillance, it's hard to talk about what conventional imaging here, but no large data sets to evaluate the role of PSMA scans in active surveillance. Some data here with PSMA scans and a GRPR PET scan. GRPR is overexpressed in low-risk prostate cancers. Still here, history, clinical exam, PSA, periodic testing, and an MRI mostly play the role. Not a big role for PSMA scan, at least in active surveillance just yet. What about castrate-resistant prostate cancer? Well, this is an area that we are seeing vanish away, which is just amazing. Because as a cancer doctor, if somebody's got cancer, you want to be able to identify where it might be in the body. In this study, 200 patients with non-metastatic castrate-resistant prostate cancer by conventional imaging, PSA greater than 2, doubling time less than 10, and PSMA scan here identified disease in 98% of those patients, 44% with pelvic disease and 55% with M1 disease. Essentially, this is eliminating this as a disease. But I do think it's important that for a regulatory standpoint, some drugs are approved in this setting and not necessarily approved in metastatic disease, at least in some countries. And I think that that is an important point to make, and where conventional imaging may play a role if it's access to specific medications. I think, however, this is probably going to go away as well. A bigger conversation is in metastatic hormone-sensitive prostate cancer. Low-volume disease is what I want to talk about first. So here are some of the data for the CHARTED study. The CHARTED study is 790 patients with new diagnosis of metastatic hormone-sensitive prostate cancer, randomized to either ADT versus ADT plus docetaxel. It was a game changer, remains a game changer in the field. But what this study showed was that patients with high volume disease, which was defined as either visceral disease or greater than 3 bone lesions, one of them being outside of the pelvis or spine, those were the patients who really benefited from the addition of docetaxel, whereas the low volume patients did not, probably had toxicity without a significant benefit. If we only use PSMA scans, we are going to move people who are low volume on conventional imaging to high volume. And we are going to overtreat a population that is unlikely to benefit from this therapy. So this, if anything, probably the most important role that the conventional imaging will play. For high volume disease, there are ongoing trials investigating the role of lutetium-177 in this setting, and therefore PSMA scan may play a role, but currently there's no data to support the fact that if somebody has widespread metastatic disease at diagnosis, that you need to get a PSMA scan. It doesn't change your management as of today. Here is the metastatic castrate-resistant prostate cancer setting. This is the VISION trial. You've all heard of it. Randomized trial, lutetium-177 versus standard of care. And what this showed was that lutetium PSMA, PFS of 8.7 months, OS 15.3, complete response rates at 9.2, gets FDA approval, game changer for patients. Here's a waterfall plot, awesome. One important thing about the VISION trial. How did you get into it? You got into it by getting a PSMA scan and conventional imaging. And you had to get the conventional imaging because you had to demonstrate that you had to look for PSMA negative lesions. So you get a PSMA scan, and you have to actually have a lesion, and then you have to get conventional imaging and show that you don't have PSMA negative, and that's how they actually got in. And about 15% of patients were excluded. So even in the castrate-resistant prostate cancer setting, thinking about lutetium, conventional imaging is needed. No data about the utility of serial following patients with metastatic castrate-resistant prostate cancer. So this is a really important thing. As an oncologist, I like to compare apples to apples. So if you've been using PSMA scans, probably important to use PSMA scans, but if you've been using nuclear bone scans, shifting to PSMA scans, and all of a sudden the patient has more disease on imaging, you don't know how to interpret that. Was that there before? Apples to apples is probably really important. It's also important to recognize that there is PSMA negative disease out there. Not all cancers express PSMA. And if you only use PSMA imaging, you would miss these lesions. And non-PSMA driven imaging is necessary to evaluate. And the optimal timing of when to do this is not clear yet. You're going to do it with CT scans. You're going to do it with FDG PET scans. PSMA-based imaging is a very valuable tool and likely has replaced conventional imaging in the localized and biochemical recurrent setting. Utility of PSMA imaging in the metastatic setting to date is not clear, and its sole use may lead to treatment strategies to patients who are unlikely to benefit. For metastatic castrate-resistant prostate cancer, PSMA imaging likely has a role in determining patients most likely to benefit. However, its sole use in disease monitoring is not clear. And then sole use of PSMA imaging will miss non-PSMA expressing disease. Thanks.